So we will be continuing our review of the case. It might seem to be small, but as we can read today, great things are done by a series of small things brought together. So we'll try just to build on what we started last time, but just a recap. So it was all about this 50-year-old male patient with schizophrenia, gout, and hypertension. This was the patient prescription on his last consultation. And just recapping from last week. So the question was it really gout without a bang? Because when the patient was seen, he didn't have any complaint arthritis-wise. So the lesson was that we got the patient in what is called intercritical period. And although it might be silent, it is louder because there are very few conditions that has a sequence that is known to be intercritical, where they might just be almost totally asymptomatic. Just by taking the history and noticing that this, instead of getting us away from gout, should rather get us closer to it. And we also learn all that matters for us, especially during intercritical phase or episode, especially if it's the first time, is to be able to diagnose the patient. And we will be learning to try to remember that there is a classification criteria that needs us to score our patient. The entry point being usually first the screening for inflammatory arthritis, as we can see there, the S factors, and taking the history and try to find out if the patient ever went through a flare that can be typical, and when it is typical, we know where which joint is usually involved, or if the patient got a flare that might not be where we expected it to be, but it is still a gouty flare nevertheless. That may involve the ankle, the instep, the wrist, or the finger, or even the elbow. So we need to be mindful of that, or instead of us always expecting mono or oligoarthritis, we might have a patient that comes to us with a polyarticular pattern of flare, especially later in the course of the disease. As we said again last time, whenever we can, and it is a skill that we need to learn, let's be able to put the needle in that joint so that we can identify crystals of monosodium urate, because when we get the crystals, we know that it is 100% specific and about almost 90% sensitive when it comes to gout, so that we know exactly what we are treating. And when it comes to the scoring, it is a 3-step scoring. And beside the entry point, the second step is that we need to have those criteria that we need to remember, being it the presence of monosodium urate crystal that we will get from the joint, or look for the presence of tophus. So as you can see, the sensitivity of monocrystal, we spoke about it. And later on, because we need to look for the crystals, we need to be able to know where to look for them. And long before the blood comes back, if we did examine our patient properly, and if we have taken the history that is suggestive of flare, we can already diagnose gout at this step. And as we see here, during a flare, if there is a presence of tophus, which is not as sensitive as the crystal are when we do the tap, but it is almost closely specific because it's just under 100% specific when you identify or we identify tophus in a patient that we suspect of having gout after we went through step 1 and now that we are at step 2. So, and if the patient is meeting all the criteria 1 and 2, there is no need for further workup. The patient at this stage can be diagnosed as having gout and be taken into the discussion on how the therapeutic plan going forward will be. So we score our patient, and when we score our patient, all that we need now, if 2 and 1 couldn't take us to gout, we will need to score our patient by using clinical, laboratory, and radiological criteria. And when we talk about laboratory, that's where the uric level comes in. And we need to know and remember that every time we talk about uric levels, there will be what is considered to be a normal range that we get from the lab. There is what we need to remember, what is needed or required for the crystal to be formed. And later on, as we treat the patient, we need to be mindful of what is the target, because the target is not always the normal range, depending on what our patient clinical situation is. So those are the things that we've spoken about. And one of the things that we need also to remember, because now at step 3, you need to, you have to review your patient uric level, is that if blood was taken during flare, it is not always easy to interpret. Why it is not easy to interpret is that 12 to 43% of patients that are going through a flare of gout, that have gout, might have normal to low level of serum uric. So this, we need to be mindful of this fact so that we don't misdiagnose patient or miss the diagnosis of gout just because blood was taken during a flare or just a few days following the flare. So this leads us to remembering that when you go, as we've spoken about before, step 1 and step 2, we don't need necessarily to have the uric level for us to diagnose our patient. It does lend an end, but it is not always diagnostic, because you might also have a raised uric acid level, but that doesn't make you gouty. And the same way that it is not always required, as we saw, when you meet 1 and 2, you can be diagnosed as having gout long or even in the absence of serum uric levels. So, and whenever the patient comes and we want to pull blood, knowing and remembering that up to 1 in 4 patients going through a flare might have normal to low serum uric level, the optimal time where serum urate level might be accurate and be useful for us to use it in the classification criteria will be to wait for 2 weeks or more after the flare for us to make sense of the report that we are receiving from the lab. And after entering all the data, being it clinical, laboratory, and radiological, in relation with gout, all that we need is at least 8 for us to diagnose our patient with gout. And the score has a sensitivity of more than 90% and a specificity close to 90%. So it is a quite useful tool to access and to refer to whenever we want to diagnose a patient with gout, remembering that this is a chronic disease and we need to make a correct call so that we don't put a patient on a long life treatment while they might not have gout. So, but whenever you see gout or think gout, you need to mind comorbidities, because whenever you see gout, you might get more than you bargain for. As we say, up to 10% of people might have at least 7 comorbidities, and these are the different comorbidities that we've spoken about. And among these conditions, one of the significant one is hypertension, and that is why it was mentioned last time. The second reason why hypertension was mentioned is that hydrochlorothiazide, which is one of the first line treatment that we use for hypertension, is linked to increasing uric acid and causing gout. But the reason also why we wanted to bring up this issue is that at the time we forget or we don't read the small print to notice that even furosemide is also linked to increasing uric acid and linked to gout, and furosemide more strongly even than hydrochlorothiazide. So whenever and this will be guiding us in either when the patient needs necessarily these drugs, for us to know that the requirement in urate lowering therapy might be higher because these drugs are on board. And as you can see, not only hydrochlorothiazide and furosemide that are without any doubt linked to gout, even spironolactone, when patients are CKD, might contribute to increasing uric acid. It's just for when we know this and we struggle to get the patient control or to get the patient on target, we need to understand and not stop in the middle and delay escalating our treatment so that we get the patient to the specific target. Again, one of the learning point or take-home message from last week was that we needed to remember that furosemide is not a first-line therapy for hypertension, but there will be specific limited instances where we will call upon furosemide to come help us manage hypertension. But this will be furosemide taking the space of hydrochlorothiazide, but not combine to hydrochlorothiazide. And in South Africa, it will be when the eGFR is less than 45, or when your patient is like all over the world, heart failure, pulmonary edema, or body fluid retention. So they are the message was through this discussion for all us to agree and unlearn and relearn that furosemide should only be used for hypertension in these specific instances. And it is coming to replace thiazide, not to adapt to thiazide when it comes to hypertension. And furosemide should never be considered to be more effective than a thiazide, and it will never be a first-line therapy for hypertension if these criteria are not met. So, and the last issue that we dealt with last time was that we needed to be mindful that not only we treat hypertension, but we need to treat hypertension with the recommendation, the most current recommendation in mind is that there is almost no more, very few indication for monotherapy, is that almost every single patient should be offered combination therapy from the beginning because it is more effective, it is safe, we should not be worried about side effect. And on top of that, the benefit is that we achieve rapid control in a short period of time, and you get your patient to not only benefit from the reduction of cardiovascular or bad outcome, but also the reward that they've achieved the target that we long and they long for. Because whenever we delay controlling our patient, there is a price to pay. So, but now that we know every single patient diagnosed with hypertension should be or is eligible for combination therapy, we need now to learn that there are only 3 situations where monotherapy can be considered. It is only when you deal with a very old patient, which is not unusual in our setting, when you deal with a frailer patient, and when you deal with low risk grade 1 hypertension. Those are the limited clinical instances where after diagnosing somebody with hypertension, you might consider monotherapy. So if we talk about low risk grade, it means that whenever you diagnose hypertension, you need to score your patient risk, cardiovascular risk. We've spoken about this when we did the dyslipidemia. It means that we can use the Framingham CV risk assessment that need all those variables to be available to us to later on calculate what is the percentage. We usually struggle whenever we want to use some of the calculators that we have on the different app, and you will end up, if you did manually by entering the value and using the table, you will end up having a score that is usually different from the score that you get from the calculator. So it's not always the same, except for this particular one. So if somebody want to use the Framingham and instead of using the table, this is the link or the calculator that will give you exactly the same risk as the one that we get when we use the tables that were provided by the guideline for dyslipidemia. So this is just something that we need to do. So you don't need to flip the page and try to find which line where your patient falls in. You just enter the data and you get exactly the same score in a very few seconds. The only issue is just to be mindful of the conversion from from the metric to the international. So you need to care about the conversion of the value that you get, that you need to enter. We know how we grade our patient, but again, you only use the Framingham when it is applicable. So we need also to be mindful of the fact that there will be patients, especially those that fall under very high risk, and the high risk that literally don't need a calculator, and not a day or a week passes without us getting colleagues that would have scored a patient excited to apply the Framingham calculator, but forgetting that those patients shouldn't have been entered in the data shouldn't have been entered in a calculator, because usually this patient will be, the risk will be underestimated. So another way of, especially in hypertension, when you wanna prescribe treatment and you diagnose your patient, it is to use the simplified classification hypertension risk. These slides are linking just trying to remind us some of the clinical situation where we don't need to calculate using the calculator for us to assess the risk. Is that restricting ourselves to the topic today? Whenever you have a patient with a grade 3 hypertension, that patient is automatically a high risk. You don't need to enter any data. You just record that patient as a high risk. As we can say, you don't calculate this patient. You must recollect, you must just remember who they are and grade them. So high risk, a LDL of greater than 5 or greater, total cholesterol greater than 8, blood pressure equal or greater than 180, meaning a grade 3 hypertension is automatically high risk. You don't need to calculate. But in the setting of hypertension, there is a heat map that is a simplified way of assessing cardiovascular risk for hypertensive patients. It is called Simplified, but our simplified classification is, it might not be that simple, because you need to take the patient history, you need to assess the patient for organ damage, and you need to assess patient for diseases that will impact on the heat map. So how many times did we use this table? So this table is there using the risk factor, the organ damage, and the concurrent diseases that can be on the patient, and the grading of hypertension. As you can see, grade 3 doesn't appear on this table because grade 3 is automatically known as high risk. That's why grade 3 doesn't appear there, although we know that hypertension is graded from high normal to, from optimal, high normal, grade 1, grade 2, and grade 3. But when you assess risk using this heat map, grade 3 doesn't appear, because by now we all know that grade 3 is automatically called high risk. So, and things that we need to remember is not only that table, but this table also that give us not only the major risk that we need to look or work for on our patient, but also all the hypertension mediated organ damage that we need to screen for by means of EKG, urine, albuminuria, and assessment for potential complication linked to the fact that the patient has hypertension. So this is the heat map, just to give us an idea of what happens. So that's the simplest way. You recognize that your patient doesn't need Framigam, then you use this. But for you to be able to take advantage of this, you know that you still have work to do by taking the correct history, by examining your patient properly, and by running some tests that are needed for that. So this was the treatment for our patient. And as you can see, our patient had a abdominal circumference of greater than 92. So our patient was a grade 1 hypertension, but had at least one risk factor. So this patient was definitely not a low risk grade 1 hypertension, and the prescribing monotherapy for this patient was a suboptimal management by current standard. Not only it was suboptimal, but because it was monotherapy, but it was also suboptimal because we prescribe enalapril and we tend to forget the implication of us prescribing enalapril. First, for us to prescribe enalapril, we need to have a baseline potassium, urea, creatinine. We know the patient is already hypertensive, so it will not matter that we know the blood pressure in particular, but those chemistry from the kidney function need to be established as we prescribe enalapril, because enalapril is associated with a risk for AKI, increase creatinine, decrease urine output, and increase urea. And the increase in creatinine is expected to be around 20 to 30% from the baseline, and it will usually stabilize later on. When do we expect that to happen? It is expected to happen within 2 weeks. Reason why we should recheck ideally again once we've prescribed creatinine to our patient. Even when it is indicated, we were still bound for the patient safety to go back 2 to 4 weeks later, recheck these test or this function or this electrolyte for us to know that it is safe for our patient to carry on. So it is endorsed by South Africa now. The first step that used to be one drug should be now a dual therapy with low dose. When we say low dose, or when they say low dose dual therapy, it is basically half full dose. So for every single drug that is used for hypertension, we know the starting dose, we know the target dose or the maximum dose. So whenever we want to put the patient on treatment and start the patient on treatment, whatever combination was chosen for our patient, we needed to know that the first step should be using half full dose of 2 drugs combined that we offer to our patient. But again, it is not only about offering a combination, but also remembering to individualize treatment. We will be individualizing treatment in our setting according to race, and according to race, the most effective combination for Black people based on this paper, the Creole study, is that hydrochloric. So it is basically the anchor is amlodipine. Amlodipine combined with hydrochlorothiazide or amlodipine combined with enalapril are the most effective combination in Black people. So now that we've learned that most of our patients will require from the get-go a combined therapy, then because the majority of our patients are Black, the most effective combination that we should be going for will be either amlodipine and enalapril or amlodipine and hydrochlorothiazide as a first choice for Black patients with hypertension. So these are just the data to back up why we should be going for those pairs of treatment. But as we talk about hypertension and individualizing treatment, we should not individualize only in